Welcome to The Explainer, where we break down really complex topics. And today, we are jumping right into the deep end, into the high-stakes world of massive transfusion. This is truly a race against time to save patients from catastrophic bleeding.
Okay, so to really get a handle on this, we've got to start with the absolute core problem that trauma teams are up against every single day. What is this vicious cycle that can actually make bleeding unstoppable?
Well, the answer is something called the lethal triad. And look, this isn't just a simple list of problems. It's this absolutely terrifying downward spiral. You've got coagulopathy, that's when the blood just can't clot right. Then there's acidosis, the blood gets too acidic, and hypothermia, a big drop in body temperature. The scary part, they all feed off each other, and that's what leads to this massive, uncontrollable bleeding.
So how do you fight back against something like that? Well, hospitals have this pre-planned, ready-to-go strategy. It's called a massive transfusion protocol, or MTP for short. You can think of it like an organized, all-out counterattack designed to break that deadly cycle. So let's start by getting a closer look at the crisis itself.
All right, first things first, let's really dissect the enemy here. We need to understand exactly how a patient gets trapped in this feedback loop of just getting worse and worse. How does a serious injury turn into a catastrophic, unstoppable hemorrhage?
And this slide really visualizes the core problem perfectly. You can literally see the triad, hypothermia, acidosis, and coagulopathy, just circling the patient, feeding off the hemorrhage, and in turn, making that hemorrhage even worse. It is the definition of a vicious cycle.
Okay, so let's break this down step by step. It all starts with massive blood loss, right? That leads to hypothermia, because the body just can't keep its temperature up. Then, that cold starts to mess with the platelets and clotting enzymes, which worsens what we call coagulopathy. Basically, the inability to clot. From there, you get poor perfusion, not enough oxygen-rich blood getting to the tissues. And that lack of oxygen, it causes acidosis, a big drop in the body's pH, which then, you guessed it, inhibits clotting even more. And as you can see, it all just feeds back on itself. In fact, nowadays, a lot of people are calling it the lethal diamond, adding hypocalcemia, that's low calcium, as a fourth, supercritical point. And that happens because the stuff that used to store blood products, citrate, it actually binds up the body's calcium. And you absolutely need calcium for clotting.
So, you've got this deadly spiral kicking off. How in the world do clinicians on the front line know when it's time to pull the trigger? When do they sound the alarm and activate that MTP?
Well, they're looking for some key warning signs. And these aren't just random numbers, they are clear signals of shock. I mean, a systolic blood pressure below 90, that tells you the pump is failing. A heart rate over 120, the heart is desperately trying to keep up. And a positive bedside ultrasound, well, that can show you life-threatening bleeding on the inside. Any one of these, in a patient who's bleeding, is basically a giant red alert that a massive transfusion is probably their only shot.
And this slide really highlights a huge challenge, the race against time with lab tests. Your traditional lab tests, like an INR, they're accurate, sure, but they're done in a central lab, they take time to get back, and here's the kicker, they're run at a normal body temp, 37 degrees Celsius, not the patient's actual temperature, which is often way too cold. On the flip side, you have these newer bedside tests called viscoelastic assays. These things give you a real-time, functional picture of clotting using the patient's own blood at their actual temperature. And when every single minute counts, that speed and that real-world accuracy are just absolutely crucial.
Okay, so the alarm has been sounded, the MTP is activated. What happens next? Well, an entire arsenal of blood products is rushed to the bedside. So let's take a look at the key components, the tools they use to fight this battle.
First up, the one you'd probably guess, red blood cells. Their job is pretty straightforward, but absolutely vital. They're the oxygen carriers for the whole body. When a patient is bleeding heavily, their ability to carry oxygen just plummets. And without these cells, the vital organs start to starve and shut down. That's a state we call hyperperfusion.
All right, next up we have plasma. Now, if red cells are like the delivery trucks carrying oxygen, then plasma contains the entire construction crew and all the materials for making repairs. It's packed with something called coagulation factors. A great way to think of it is as the glue for the clot. It provides all the essential proteins you need to build a stable framework and actually stop the bleeding.
Then you've got platelets. So if we're sticking with our analogy, if plasma is the glue, platelets are the emergency first responders. These are these tiny little cell fragments that are the very first to show up at the scene of an injury in a blood vessel. They immediately stick together and form an initial, kind of temporary plug that kicks off the entire clotting process.
And finally, we have something called cryoprecipitate. Now, the name might sound a little complicated, but what it is pretty simple. It's a super concentrated product that's loaded with one key ingredient, fibrinogen. Fibrinogen is the final building block that forms this strong, cross-linked mesh over that platelet plug, creating a really durable, stable clot. So, when a patient's fibrinogen level is critically low, cryo is the tool you grab to fix it, and fix it fast.
Okay, so we've got the tools, now what's the battle plan? You see, a modern massive transfusion protocol isn't just about, throwing blood products at a patient and hoping for the best. It's actually a really sophisticated two-phase strategy.
Right, so this is the crucial point. The strategy actually evolves in real time. You don't start with precision, because you just don't have the time for it. You start with phase 1, which is this ratio-driven, kind of blunt force approach. The idea is to give a balanced mix of everything to just buy some time. Then, as the information starts rolling in, you shift to phase 2, the precision strike, using lab data to target exactly what the patient is missing. So that initial phase, it almost always uses what's called a balanced ratio, and the most common one you'll see is 1 to 1 to 1. That's 1 unit of plasma for every 1 unit of platelets and 1 unit of red cells. And the thinking behind it is simple. You're trying to replace the blood in the same proportions that it's being lost, basically trying to mimic whole blood. This was a huge shift from how things used to be done, and landmark studies like the proper triumph showed that this approach was way better. It actually reduced deaths from bleeding out. But the second those lab results start hitting the computer, the team immediately switches gears to this goal-directed approach. So now, instead of a fixed ratio, they're hunting for specific numbers. Is the fibrinogen below 150? Boom, give cryoprecipitate. Is the platelet count under 50,000? Give platelets. It's all about using the right tool at exactly the right time to get that clotting function back to normal as fast as you possibly can.
And you've got to remember, this strategy is not one size fits all. Not at all. The reason for the bleeding matters a lot. For a trauma patient, where clots can break down way too quickly, they'll give a drug called tranexamic acid, or TXA, to help stabilize them. But let's say you have a massive GI bleed from swollen veins. You actually avoid that same drug because it could cause dangerous clots somewhere else. It's a really smart, highly tailored approach.
Okay, that was a really rapid overview of a super complex and dynamic process. So what are the absolute key takeaways? What do you need to remember?
Look, if you remember anything from this, make it this checklist. Number 1, fight that lethal cycle immediately and aggressively. Get the patient warm. Number 2, start with a balanced 1 to 1 to 1 ratio to stop the free fall. 3, the second you have data, you switch to precise, goal-directed therapy. And number 4, use your other tools, like TXA, wisely, and base that decision on the specific reason the patient is bleeding.
And here's why all of this matters so much. Around 40% of all deaths related to trauma come down to one single thing: uncontrolled hemorrhage. These aren't people dying from the initial injury itself, but from bleeding out afterwards. That is a staggering number, and it's the exact problem that massive transfusion protocols are designed to solve. And, the logic behind this entire strategy actually has its roots in military medicine. That 1 to 1 to 1 ratio, that wasn't dreamed up in some pristine civilian lab. It was born on the battlefield out of pure necessity. The goal was brutally simple and brutally logical. Replace what's being lost in the form that it's being lost, as whole blood.
And that military history brings us to one final, really thought-provoking question. You see, for decades, the standard has been to break blood down into all its different components. But now, we're seeing this resurgence in using whole blood itself, especially in major trauma centers. So you have to wonder, are we witnessing a full circle moment here? Is the future of resuscitation actually a return to its most basic and maybe most effective origins? Thanks for joining us for this explainer.